All right, we are on the second to last session of the 24-hour marathon. We're going to go up north to Canada and have some of our Canadian brethren take over. Mark Glazebrook is a dear friend from Nova Scotia. He's going to take over as your moderator. Thanks, Mark.
Well, thanks, Selene, and congratulations for another great meeting, and congratulations to your foundation. You have a wonderful thing going here, and I hope everyone's able to support you. Tonight, for this hour, we're going to talk about ankle fusion. I'm a bit of a fuser. I've done my share of replacements over the year and studied both fusions and replacements. I'll give you my perspective, but we've been assigned the fusion arm of this night. Bernard Burgesson is here live with me. Bernard is I'll introduce him shortly. He'll be up third. I don't have two of my speakers, Dr. Jim Stone, who's on an airplane as we speak, and Dr. Joel Morash is at a big hockey tournament in Ottawa, so he couldn't make it tonight. He's on the ice as we speak. But we have videos from them, and without further ado, we'll get to the first talk on open anterior approach ankle fusion. Dr. Joel Morash has provided the video for that. We'll run that, and as long as everything's working, we'll be good to go.
I am Joel Morash. I'm one of the foot and ankle surgeons up in Halifax, Nova Scotia at Dalhousie University. I work with our moderator here, Dr. Mark Glazebrook, and in our group for this next hour, we'll be talking about treatments for ankle arthritis and forms of fusion. And my discussion will be about the anterior approach to ankle fusions. As disclosures, I am a consultant for Stryker and Arthrex, however, not much of that will apply to today's discussion. So before we get started about the topic of anterior ankle fusions, we obviously want to understand what we're treating. So as we all know, ankle arthritis is in the tibial talar joint, and it's unlike hip and knee arthritis. Well, the primary OA only accounts for less than 10% of all the cases. So most of the arthritis that we're dealing with is going to be post-traumatic, being over 60%, and other etiologies such as RA, AVN, neuropathic, sepsis, hemophiliacs. See those sort of wood splitter injuries or P-lines, you know that this is going to go on to arthritis, often within the first 2 years. And it's a mixture between articular damage at the time of injury, AVN, whether that's within the bone, the tibial plafond, or the talus, infection due to some of these being open, and obviously high risk with a soft tissue envelope, an inadequate reduction, which is sometimes very difficult with these severe injuries. The mechanical properties of the ankle do protect against primary OA, but that also may predispose it for post-traumatic arthritis. It has a uniform thickness cartilage, which is quite a bit thinner than that of the knee. And then the pressures change through our gait, sort of helping with cartilage nutrition. But obviously this causes a stiffer, more uniform joint on the more superficial layer, which can be more resilient with aging. In terms of classification, these are obviously helpful from a radiographic point of view to help characterize, or from an anatom or from a research point of view to help study these treatments in terms of. For this, we won't get into too much of that now, and that also goes for the COFAS classification of ankle arthritis. And this is often a lot more helpful, like I said, with research and in discussion, sort of the benefits of fusions versus replacements in that sense. So as we all know, when people present to our clinic with ankle arthritis, typically it's pain with weight-bearing activities. They may also have rest and night pain, decreased range of motion. This can be secondary to the arthritis, bony blocks, or also the post-traumatic stiffness or post-surgical stiffness. They can have pain on palpation, decreased range of motion. And the alignment of the foot and ankle can be in all, whether it's varus, valgus, anterior, posterior translation. It can be, we kind of deal with all sorts of deformities, but we also want to make sure that we assess the knee and the foot when we're also dealing with the ankle, the whole lower extremity, to make sure that when we are discussing fusions as we are today, that position of the fusion is adequate or thought about based on the joints above and below. Obviously, a neurovascular assessment is going to be very important with protective sensation, skin quality, scars, and previous surgeries, helping dictate a lot of our treatment as well. We always want to get proper imaging. This can be in terms of x-rays. So always try to get weight-bearing x-rays, AP, lateral, oblique, and hindfoot alignment views. foot views or sort of lower extremity views or full standing views are all dependent in my practice based on the physical exam. So if there is clearly a foot deformity or some lower limb deformity or a history of trauma in that way, we'll get those appropriate views and weight bearing as possible. And this will help with our, again, positioning for the treatment going forward. If there's ever any concerns about possibly bone stock, a better evaluation of the actual anatomy itself, some cystic formation, or actually even where their pain is coming from, it's sometimes difficult to fully assess whether it's in the ankle or not. A CT or CT SPECT scan can be helpful, again, for pre-op planning and ensuring that what we're treating is actually the ankle itself. I won't belabor the non-operative treatments, but we all know in terms of activity modification, weight loss, rocker bottom shoes, and bracing of all sorts, whether it's an ASO to an Arizona brace. So for this talk, the main goal is to discuss surgical treatments. We're not going to discuss arthrodesis versus replacement. This is the people who we've gone on to discuss arthrodesis. And in my practice, I typically do arthroplasties, and if I do end up fusing the ankle, for the large portion of them, they are done arthroscopically, as you see there to the left. The other option is, but you'll hear about that at a later talk. You also notice there the lateral transfibular approach with a fibular osteotomy, done there in the central picture, and then the anterior approach done with an anterior plate and a cross screw configuration there on the right. And that's what we'll be talking about. So surgical treatment, how do you choose between those three? So for me, there's a lot of information comes into play with that, and it's very independent patient to patient. So obviously, if they're diabetic, may be looking for a more rigid construct, or also maybe looking to minimize my incisions. So that may change one way or the other. Vascularity, smokers, you may be trying to minimize, again, any sort of incisions or wounds. Old incisions and wounds, maybe they've had previous trauma, hardware placed in, removed, or they've had old infections at the time of a previous surgery or injury. Surgeon familiarity. So obviously, if you're comfortable doing one or the other, that often is going to push you obviously towards that direction. And for me, that is more familiar with arthroplasty. I do feel that if I'm not doing an arthroscopic approach, I typically would do it. And I'm doing it open, it will be an anterior approach, as that helps me understand the alignment. And the surgical approach is a lot more similar to the remainder of my practice. You can discuss conversion in the future. I think that is dependent upon the patient, obviously, as well. If that's something that you're discussing in a young patient that may be looking for an ankle replacement in the future, having that in mind when you pick your procedure. And obviously, the deformity in the leg, ankle, or foot, as we spoke about earlier, can dictate sort of where you feel you can best correct that. So today we're going to talk about we'll talk about the anterior approach that you see there to the right. And the operative approach is very similar to a total ankle, where you're going to come in on the anterior incision. I position mine just slightly lateral to the edge of the tib-band tendon, going down to the TN joint. There is discussion about angiosomes, and if you've ever heard Dr. Tim Daniels speak, it was quite passionate about the angiosomes, and because if this wound does break down, that's a significant complication and life-changing for your patient. So definitely something to think about. I currently haven't converted myself over to that, but it is definitely a concern for a lot of patients, whether it's ankles or anterior ankle fusions. But the anterior plate gives you a very stiff construct. I feel like you can correct a lot of deformity from this approach, whether it's varus or valgus. You get the access to the gutters to help debride that, and if you need to bias your preparation in the tibia, it does give you a little bit further correction that you may need to help with that. Also, if there's poor bone quality, you have these larger locking plates and that cross screw that you can position either medial or lateral, depending upon your comfort, giving some nice derotational support in the body, which is obviously a great bone. And it also offers you possibly a future conversion to a total ankle. However, some may argue that leaving that tissue native to come back for a total ankle and doing it either arthroscopically or through a lateral approach may even actually be better. But again, I think that's a dealer's choice going forward. So how do we do this? After we've made but first it's always going to start with positioning of the patient. I position the patient supine with a bump under their ipsilateral hip, position their ankle to be straight to the sky, put flannels underneath it, and then I have a sterile bump. I find the sterile bump helps me position the talus within the tibio-talar joint for a fusion. So if I need to bring it back, I can place that on the distal tibia, and if I need to bring the talus forward, I can position underneath the heel. So this helps me position in a sterile fashion. And then C-arm, and that's dealer's choice. I like the large C-arm. I feel like it allows me to have more hands free. It doesn't have me coming off the table. And even though I think they're both very difficult to keep sterile completely, I do find the big C-arm just minimizes some attempts of contamination. So once we make our anterior incision, just lateral to the tib-ant tendon, you're going to find the superficial down there laterally. I pay careful attention to protect that throughout the case, and I do not make any further medial exposure at that time. I leave that tissue untouched. I see the EHL tendon sheath, which I sharply transect through because I'd like to close that as a soft tissue envelope at the end of the case. And then I mobilize the deep neurovascular structures. Usually, if you come up to the top of the tib-ant and see its muscular transition into its tendon, you can make Mettenbaum scissors and move that over, and then slowly mobilize it going distally. And then I take that laterally and protect it throughout the case. And then I use a Bovie to perform my arthrotomy. So this is an ankle that we're looking at to start off. Obviously some slight valgus within the ankle, and we've chosen to go on to do an anterior fusion for reasons that we spoke about before, making my anterior incision. And then once we get in there, we look at the joint. As you can see there to the left, the congruency within, after I've attempted to prepare it, there is no congruency within the talus to the tibia. It's slightly anterior translated as I've kind of sulcused out a little bit anterior in the tibia, but it does look, and it can give you a sense of mal reduction anteriorly, as that looks like it has good bony compression. So you want to make sure that on both views, you're happy with the reduction going forward. And I really want to bring that anterior aspect of the posterior facet in line with the central portion of the tibial plafond to help with a nice lever arm for this fusion. So for this, there's a few different options. I can use a curette to help contour this out. I also like to use a burr. I usually use a 6 millimeter to 8 millimeter acorn burr. The acorn burr is nice as it doesn't, it prevents any sort of wrapping up of the soft tissues coming in, as it only turns at the very end of the handle. And I find that's very nice for contouring. And again, possibly with some irrigation in low speed to prevent any heat necrosis. But I want to contour it so you see that there's a better sulcus there on that fits the talar dome on that right side. And right through here. And now I've actually brought that anterior aspect of the posterior facet more centrally within the tibia. Occasionally on the anterior, you'll have a difficult time getting compression, so you definitely want to also look at the anterior views, the AP. And sometimes I find that this is just because of the old osteophytes, that you actually get some impingement within the gutter. So you can see here, there's a small impingement on the medial side in that medial gutter. And once you remove that with a rongeur or burr, curette, or saw, dealer's choice, it will allow you to bring that back. So sometimes that's actually inhibiting you from even getting that talus back into the tibia on the lateral because you'll be caught up there anteriorly. And it also may force you to want to plantar flex as the wider part of the talus comes up and then gets caught. So just be aware of that and look on all views to ensure that you're happy. Once we get rid of that, you can see on the right that then wants to sit in with nice compression. Again, verify that on the lateral as well. At that point, I put a K-wire across. As you can see there, a percutaneous K-wire is being started. I like to go immediately, paying careful attention to the saphenous nerve to not damage that. And I pass that across. This is slightly distracted at this point, but just to give you an idea, placing it into the body to ensure that I'm happy with its position, and I verify on the AP and lateral again that I'm happy. At this point, I put the plate on and see exactly where that's going to sit. As you can see up at the top, it is slightly off bone, and I'll bring that point up in a bit. But I would like to see that my K-wire is in a good position, my plate actually going to fit, and making sure that the anterior aspect of that plate doesn't jump over into the TN joint. And there are many different types of plates, and everybody's anatomy is a little bit different. So just keep that in mind, that you want to have a short, often a short front of the talus, on the talus. And then I verify that on AP, as you can see there. And what I want to do now is burr this out. I again take that acorn burr and I burr out a little trough for this plate to sit flat. So on the lateral, you can see on that right side that it will make it sit more flush. And that way, when you lock it out distally and then either compress through the plate or reattach the plate or put your locking screws in your plate, you're not levering that down and bringing that, malreducing your ankle, which you often want to bring that forward. And I'll show you an example of that in the future, in a few slides coming up. But also, if you look on that lateral on the left image there, I basically bovie around the plate, and then I make a little trough for it to sit in, so it sits nice and flush and doesn't cause that malreduction. So then I would take the plate off. I take do my burring, move the K-wire back to the level of the joint, flatten that off in the front, and then I prepare my joint. And that allows for any types of compression when we put it to go straight up instead of anterior. Once I prepared the joint, and again, I will use basically a 2 millimeter 2.5 drill. And you can see kind of those farage holes in through there. We over prepare the joint, if anything. I then use a small 1/4 inch osteotome to further fenestrate the joint, and then get my positioning. At this point, I pass 2 K-wires, but usually most of the time it's just 1. And at the same time, it's bone graft if needed. Most of these people, if I'm not doing an arthroplasty and they're not young getting an arthroscopic fusion, these are typically some of my higher risk patients. So for that reason, I'm often using some sort of bone graft or some sort of bone graft augment to help with that fusion. On the right side there, you can see that I locked it distally. So your 2 options are to either put your compression screw across with a 7 millimeter screw on that medial side of that K-wire, or you can compress through the plate if you're happy as well. And this time I compress through the plate, through the oblong hole in the tibial metaphysis after locking it distally. Again, this is why it's important to make sure you have that plate contoured perfectly, because if you're going to compress up, it's going to go up in the vector, that is the shape of the plate onto bone. Then even if I haven't compressed originally with that medial screw, I typically put in for some rotational stability and often use a partially threaded screw, even though it's most likely the compression has already happened. And then I fill up my remaining locking screws within my plate for a solid construct.
Okay, so we're going to leave it at that. In the interest of time, we have to move along to get the other speakers' talks in. So there you go, anterior approach to a fusion. Thank you, Dr. Morash, for that. So I'm going to talk about the lateral approach. This is a technique I published in Foot and Ankle Techniques, Surgical Techniques. We call it the FISO, Fibular Sparing Z Osteotomy. No significant disclosures for this talk. So how do we treat end-stage ankle arthritis? Good surgeons use non-operative treatment first. We all know that. And then there's these surgical options. It really comes down to fusion versus replacement. We did report intermediate results on our COFAST database back in 2014. The money slide for that was really a study with 380 patients. These 5-year intermediate results showed that both replacement and fusion works well. What we did note in that study, this is 5-year intermediate outcomes, was that there were more reoperations for total ankle arthroplasties, and I think there's more literature to support that. The revisions were 2 times higher for total ankle arthroplasty, and that was a bit concerning. So the latest study, we're just about to publish this. It's been submitted to JBJS, and we'll be presenting it here in Canada in our summer meeting. This is a 10-year follow-up now. Our COFAST database, fusion versus replacements, is 10 years out. You can see that there was some significant difference in the cohorts. This would include the total ankle patients were older, they were smokers, and they had inflammatory arthritis. Once again, you can see that we have more reoperations in the total ankle cohort. The clinical outcomes were the same for raw data. The total ankle arthroplasty tend to be a little bit better on the raw data, but when you looked at the adjusted data, there was no difference in clinical outcomes. So we're arriving at the same conclusion we had at the 5-year term, where total ankle arthroplasty and fusion gave similar clinical outcomes. But again, at this 10-year graph, when you look at fusions versus replacements continue to have more revisions or reoperations. So let's look at ankle fusion then, since we still think it's a good operation, and some would say it remains the gold standard. It's the most common surgery still, but ankle arthroplasty is definitely picking up. 90% complication rate, 10% complication rate, high patient satisfaction. Open arthrodesis is the way I do this. The benefits of open arthrodesis allows correction of almost any pre-existing deformity, especially from the lateral approach. Gives you good exposure to get alignment. Decreased operative time. You can move through this very quickly compared to an arthroscopic fusion. You don't need any real extra experience, especially the lateral approach. It's an approach we're all very familiar with, and it provides an optimal fusion rate. So here it is. This is the fibular sparing Z osteotomy, again, published in Techniques in Foot and Ankle Surgery. This is a lateral approach. The fibula is opened with a Z osteotomy, gives full lateral exposure to the tibio-talar joint. We decorticate the tibia and the talus through this open door, insert the hardware, and replace and fix the fibula. I'll take you through this. The good thing about the anatomic open lateral approach is it preserves the malleoli. I mean, this is important down the road if you ever need to convert a fusion to an ankle arthroplasty. If you sacrifice one or two of the malleoli, you cannot do a conversion to an arthroplasty down the road. So the first step of the physio is to do your Z osteotomy. You can see here in this picture that it's a straight cut in the sagittal plane and then a small cut in the axial plane on the two superior and inferior limbs of this this osteotomy. Once you open this up, you're going to see you have a nice fitting osteotomy. It's the most simple fibular fracture you'll ever ever fix at the end of the operation. Okay, so once you get the fibula reflected posteriorly, now you can see you got very widespread exposure to this ankle joint. I mean, you can see the entire surface, lateral, anterior, and posterior. Of course, you can't get the medial malleolus, but that's not necessary for a complete fusion here. Once you get your cartilage debrided and fenestrate the superior and inferior surfaces of the ankle joint, I usually mix in a little bone graft. I use augment and the patient's own local bone graft. So when I'm harvesting the tibia and talus cartilage, I'm very shrewd to take the quality bone off this cartilage and mix it with bone graft for insertion here. At the end here, next we're going to put our screws in. I use a cross configuration of the screws. So these are large fragment screws. I enter the first screw from inferior to superior, so just above the subtalar joint, posterior to the sinus tarsi. And then the second screw comes down from the tibia into the talus. You can look at your position of your fusion before you put your screws across the guide wires to be sure you're happy with the alignment of the ankle. Of course, with the fusion, this is most important. You need to get that foot at 90 degrees. You want it neutrally rotated and slight valgus in the coronal plane. I find if you reduce the ankle joint against the medial malleolus and maximally dorsiflex the talus, you're going to automatically get the appropriate position for your fusion. You can see here we're inserting the screws. I always do the inferior screw first to drive the talus up into the ankle mortise. Then I add the superior screw to get a leg effect of the talus back into the mortise as well. Your final construct seen here in the bottom right corner, it's ideal to have your screws parallel on the lateral with separation to give good rotational stability. And you can see the screws are centrally placed on the AP projection. So this is the ideal screw position for your final construct of your lateral approach arthrodesis. Okay, so the advantage again, this is an easy approach. You should all be very familiar with the lateral side of the ankle. There's no major neurovascular structures there. We fix ankle fractures all the time, and it gives really good exposure. There's less wound healing concerns for a lateral versus anterior approaches. No neurovascular structures. You convert it to a total ankle down the road because it's anatomic, leaving the malleolus intact. And because the malleoli are intact, it's a more stable construct, as such, maybe decreasing the non-union rate. So in the end, which is best, fusion versus replacement? I can't leave this topic without putting this slide up. This is the COFAST classification for different types of fusions, ankle arthritis. Type 1, isolated ankle arthritis. Fusion or replacement is a real good operation here. Either's good. Type 2 with intra-articular deformity. Both work well here, but you must correct the deformity, and that's a challenge for total ankle arthroplasty. So for type 2, you might be safer to do an open arthrodesis, and that can be done easily through the lateral approach with the physo. Types 3 and 4 with extra-articular deformity and periarticular arthritis. We're showing some data now in our database at COFAST that these may be a little better for an arthroplasty. So it's really not which is better, fusion versus replacement. It's which operation are you going to choose for which type of arthritis. And this is some of the data showing you types 1 and 2 ankle fusions and replacements are similar. When you move on to the more complex types 3 and 4, total arthroplasty seems to be performing better. So in summary, open ankle arthrodesis treats most end-stage ankle arthritis, corrects deformity, a lower complication rate. It's well studied with a 90% satisfaction rate. Clinical outcomes are equal to total ankle arthroplasty in the COFAST database and other supporting studies. You need to be careful with the fusion and COFAST type 3 and 4. Thank you very much.
I'm going to be talking about surgical approaches to ankle fusion, specifically the medial or anteromedial approach and the posterior approach. When it comes to history presenting illness, examination findings, non-operative management, and fixation and joint preparation techniques. We're not going to dive into that because Dr. Morash and Dr. Glazebrook have already touched on that. So without further ado, so a quick background. The ankle joint sees more weight-bearing force per square centimeter than any other joint. Post-traumatic arthritis, as we all know, is the most common cause of end-stage ankle arthritis. You look at a study published in JBJS in 2012, actually by Dr. Glazebrook and Dr. Dunbar. They found that the physical and mental disability associated with end-stage ankle arthritis was similar to that seen with end-stage hip arthritis. And as Dr. Glazebrook touched on as well, ankle arthrodesis has long been viewed as a gold standard for treating end-stage ankle arthritis. However, with improvements in implant design and instrumentation, ankle arthroplasty is catching up and is a viable option with good outcomes. The concern with that obviously is the longevity of the implants, which we're still trying to figure out. So approaches, we've talked about the lateral approach. With Dr. Glazebrook, we've talked about the direct anterior approach. There's also the arthroscopic approach, which we'll touch on very soon. And then there's also the mini arthrotomy, which is visualized here with a small medial and a small lateral incision that allows you to get access to both the lateral and medial aspects of the tibial joint for joint preparation and percutaneous fusion. And then I'll be talking about the medial or anteromedial approach. And then hopefully, time permitting, a few more slides to talk about the posterior approach. So indications when it comes to the medial or anteromedial approach. By and large, if you have poor lateral anterior soft tissue envelope, if you have a flap anteriorly that's tenuous that you don't want to go through, the medial approach is a viable option. In a thin patient where you're worried about the thin soft tissue envelope and you don't want to employ a direct anterior approach, you can also try this medial approach or anterior medial approach. And then if they've had a previous medial osteotomy, for example, or a supramalleolar osteotomy to treat or temporize the arthritis and limit progression to end stage, but unfortunately it's progressed to end stage, you can always go through that same incision to take out the implants and carry through with the arthrodesis. So we've talked about this a little bit. Dr. Morash touched on this. This, I think, is a really cool paper by Dr. Tim Daniels, a technique paper published in FAI in 2012, describing his version of the anteromedial approach and the benefits of it for both ankle arthroplasty and ankle fusion. So in the paper, they present this case example of a patient who initially was treated for a pilon fracture. If you look at figure A, this was the standard incision used and the scar present, highlighted with the black dots. The patient unfortunately went on to develop end-stage ankle arthritis requiring a fusion. So Dr. Daniels describes employing an incision like this where you have a medial limb and a lateral limb with this flap which can be elevated to expose the tibio-talar joint for joint preparation and subsequent fusion. If I'm not mistaken, I think Dr. Daniels actually, if this patient presented with no incisions anteriorly, this limb here would be a bit more medial than you see here. I think the team was forced to go a bit more central because that's where the original incision was made for the pilon fracture fixation. But more importantly, the basis of this anteromedial approach described in this technique paper really stems from an understanding of the lower leg angiosomes. And this was published by Dr. Ian Taylor a number of years ago in plastic surgery. So he describes and characterizes an angiosome as an anatomic unit of tissue. So skin, subcutaneous tissue, fascia, muscle, bone, all supplied by one artery. So you look at the direct anterior approach, for example. This involves direct dissection through skin, soft tissue, muscles, and down to bone. All this is supplied by the anterior tibial artery. Excessive soft tissue tripping, handling, retraction can disrupt the vessels that supply the soft tissues in your field of dissection and increase the risk for infection, whether it's deep or superficial, skin necrosis, wound dehiscence, which are all bad and catastrophic in most patients when an anterior approach is employed. In addition to this, the direct anterior approach, unfortunately, puts you at risk of injury to the neurovascular structures because you're working so close to them and retracting them. And if it's a long case, it is possible to have an injury to the neurovascular structures. So in Dr. Daniels' technique tip paper, his description of this anterior medial approach, if you look at the dotted red line here, has the incision between the angiosome supplied by the anterior tibial artery and that supplied by the posterior tibial artery. And the theory is that this lessens the likelihood of wound complications because that plane of dissection has supply from two different arteries. So far in fellowship, what I've seen done is essentially a modification of that anterior medial approach that Dr. Daniels discusses and describes in that technique paper. It's more of a straight incision that curves in line with the curvature of the foot as seen here. The incision is medial to the tibialis anterior tendon. And you think about this incision more like an extension proximally and distally of that medial incision used in the mini arthrotomy approach. So again, back to basics with our understanding of the anatomy and the angiosomes. What I've seen done so far this year is an incision that is straight between the angiosome supplied by the anterior tibial and the posterior tibial, as seen here. So once you make your incision, obviously you dissect through, identify your saphenous vein and nerve, protect it accordingly, identify your tibialis anterior tendon as well, make sure not to disrupt the sheet. You can elevate tibant laterally, and this allows you to get down to the joint capsule. And in do so, you can access the joint and get great exposure to the entire tibio-talar joint. So again, through this, you can perform your joint preparation, deformity correction, and fixation. Again, I'm not going to go into detail around joint preparation, deformity correction, and fixation because I think Dr. Glazebrook and Dr. Morash touched on this in detail and very well. This is a video just showing how much you can see and your exposure with such an incision done anterior medially or medially. You can use either Hintermann's lamina spreader to distract the joint, and you can see all the way lateral to do whatever you need to do with regards to joint prep, deformity correction, and then eventual fixation. So interestingly enough, this is a construct employed for the patients I just showed. If I had put up this slide at the very start of the talk, you would have assumed most likely that this was done through a direct anterior approach, but this was done through that medial approach. So it just goes to show how far lateral you can get. And this plate is central, just like you would put it with a direct anterior. But the benefit of this is your dissection is not overlying your plate, and the 2 crossing screws were placed percutaneously. So take-home messages with regards to this medial approach. It's a good and safe approach in the right patient. So if you have a patient with a poor anterior or anterolateral soft tissue or a flap that you don't want to elevate, it's certainly a good option. More importantly as well, the plane of soft tissue dissection between the angiosomes of the anterior tibial artery and the posterior tibial artery are key, and I think lessen the likelihood of a postoperative wound complication, which is certainly catastrophic in a lot of these patients when it does happen. It gives you good exposure to the entire tibio-talar joint, and then any future takedown of a fusion to an arthroplasty can also be employed through the same approach. So a few slides on the posterior approach, talking about indications similar to the medial approach. If you have poor anterior soft tissue envelope or scarring or a flap that you don't want to elevate, you can certainly employ a posterior approach, again, in a thin patient. And then if you've had a previous posterior approach, for example, for a trimal fracture or for a pilon, and the plates do need to come out, you can do everything through the posterior approach as well, in terms of extracting the implants and then preparing the joint, correcting deformities if needed, and then fusing from a posterior approach. The posterior approach is also a good option for a TTC fusion. And this is a paper that describes the use of a plate. This plate is actually an anterior ankle fusion plate that was employed for a posterior approach for a TTC fusion. In terms of a few details around technique, in the literature they describe the direct posterior approach versus posterolateral. So in the direct posterior approach, there's either sacrificing the Achilles, which tends to be employed more if you're doing a TTC, versus Achilles splitting, where you split the Achilles in half, move it on either side, and then work through that plane to get to the tibio-talar joint. And then the posterolateral approach, which is a standard posterolateral approach, which we employ for ankle fractures if need be, if there's a posterior malfracture. I think the most important thing here is that regardless of the approach that you do choose, once you get past the Achilles tendon, it's important to identify your FHL fascia and size the fascia in line with your incision, and then elevate your FHL medially. In doing so, you get great exposure to the distal tibia posteriorly, and also mobilizing the FHL medially protects your neurovascular structures, which we all know are in the posterior medial region of the ankle. This is an interesting paper as well, published in FAI in 2012, quantifying the posterior ankle exposure through an Achilles tendon split versus a posterolateral approach. And what they found was that the Achilles tendon splitting approach offered greater exposure, upwards of 33% with the ankle in neutral, and 43% more exposure with the ankle dorsiflexed. So again, one last time back through the basics in terms of looking at our anatomy and angiosomes. This is if you go direct posterior, it's an angiosome splitting approach, where you're either going through the Achilles tendon or resecting the Achilles tendon to get to the tibio-talar joint. And this offers the benefit of less wound complications. You also detension the posterior structures because you don't have the bulging Achilles to close over, especially if you do sacrifice it. So take-home messages for the posterior approach. Again, a safe approach. You just have to be careful of patient selection and do it in the right patient. Preoperative planning, as we all know, is paramount. The planar dissection is a huge benefit, being between two angiosomes, especially if you go direct posterior. And then you have greater exposure to the Achilles tendon, greater exposure to the posterior ankle, distal tibia and talus with an Achilles splitting technique. I'm going to end it there. Thank you very much.
Thank you very much, Bernard. That was awesome. Timing is great. Way to go. So the last thing we're going to show here, if I can share my screen, we're going to have a talk submitted by Dr. Jim Stone. Jim Stone is a good friend of mine and is the past president of the Arthroscopy Association of North America, so he knows a lot about arthroscopic techniques. His talk is on arthroscopic arthrodesis. And if all is well, we should be able to see it now.
My name's Jim Stone. I'm from Milwaukee, Wisconsin, and I'll be giving this talk on arthroscopic ankle arthrodesis. I want to thank Selene and Mark for inviting me to participate in this 24-hour global foot and ankle course. My disclosures can be found on the AAOS website. To start the discussion of arthroscopic ankle arthrodesis, let's take the case of this 48-year-old woman who had a plafond fracture, status post-ORIF, and has developed post-traumatic degenerative arthritis. She's failed non-operative treatment. The AP and lateral x-ray shows severe degenerative arthritis at the ankle joint, along with hardware, which will need to be dealt with during the surgical procedure. The impetus to perform ankle arthrodesis arthroscopically was the high rate of complications reported in the literature for open arthrodesis. Up to 60% overall complication rates were reported, including 20% pseudoarthrosis rate and infection rates of between 5 and 25%. Schneider was the first to report a case of arthroscopic ankle arthrodesis at an ANA meeting, and this was followed by a report by Glick, Myerson, Morgan, and Sampson in 1996 of 34 ankle fusions arthroscopic, with 33 out of 34 successful fusions and an average fusion time of 9 weeks. Let me take you through the surgical procedure as I perform it. The patient is placed in the supine position on the operating table, and the hip and knee are flexed and supported by a well-padded leg holder. The non-invasive ankle distractor is applied, and I use the 2.7 millimeter arthroscope. Routine anteromedial and anterolateral portals are placed using the nick and spread technique. And I routinely place a posterolateral portal. The posterolateral portal is used for inflow. It's very useful to have a high flow portal to remove debris in the joint. It is also useful for instrumentation, including placement of curettes and shavers in order to breathe the posterior aspects of the joint. This shows the initial arthroscopic view in the joint. There are wide areas of denuded articular cartilage from both the talus and the tibia. You can see the posterolateral inflow cannula. And then as you scan across the joint, you can see from the anterolateral portal the shaver being introduced into the joint. This lateral x-ray shows a different patient with end-stage arthritis and a large anterior tibial osteophyte. It's really important to remove the osteophyte because it allows easier passage of the instruments across the joint and easier debridement of the remaining articular cartilage using shaver and curettes. This view shows debridement of the medial gutter. You can see the shaver going along the medial malleolus. At the bottom of the view is the talus, and removing all the tissue from the medial and the lateral gutter is really important. Doing so allows the joint to be better mobilized so that you can get better visualization and passage of instruments, and ultimately, again, in the end, allows better coaptation of the joint at the conclusion of the case. After removing as much articular cartilage as possible using the combination of the shaver and the curettes, the next chore is to use a burr to remove a very small amount of subchondral bone to expose viable bleeding subchondral bone while maintaining the normal contours of the talus and the tibia. At this point, I insert the largest round burr that I can fit into the joint. Usually it's a 5.5 millimeter round burr as pictured here. And the idea is to remove just a little bit of the subchondral bone to expose viable bleeding bone while maintaining the normal contours of the talus and the tibia. My next step is to assess all of the surfaces to make sure that there's good bleeding subchondral bone. All I do, since I don't use the tourniquet, is to diminish the inflow pressure, and then I can check all the surfaces as you see here. If there are any surfaces that aren't bleeding, they can be touched up using the burr. The next step is to place the pins. The pins can be placed either using the arthroscope like this, or can be placed under fluoroscopic guidance. I like using the arthroscope because it allows me to see exactly where the pins are coming in, and that when they're advanced across the joint, they're going to enter the talus in a way that gives excellent purchase. The leg is then removed from the leg holder and the knee extended. With the ankle held in a reduced position, the pins are driven into the talus, and then the screws are placed, and good position of the pins and the screws at the end are confirmed using fluoroscopic guidance. It's really important to go ahead and get good AP and lateral x-rays and be certain that there's no impingement in the subtalar joint. The fusion position is neutral, dorsiflexion, plantar flexion. Slight valgus of the hindfoot is fine, but we need to really be careful to avoid any hindfoot varus in the final construct. The postoperative AP and lateral x-rays show good position of the hardware, avoiding hardware removal in this patient who had previous ORIF. Good position of the ankle fusion is also noted. This AP and lateral postoperative x-ray shows the more commonly used fixation for mate cross transmalleolar screws. This can also be supplemented with the so-called home run screw from the distal tibia into the talus posteriorly. That adds some definite fixation rigidity, but in my experience, I found that it really hasn't been necessary to achieve high ankle fusion rates. Operatively, I place the patients into a posterior splint until they're seen back in the office 10 days to 2 weeks after surgery. I remove the sutures at that time and then placed them into a 3D walker in neutral position. They are allowed to weight bear as tolerated at that point, and I keep them in the walker until radiographic fusion is noted, usually at around 8 to 12 weeks, and then may transfer them to a rocker bottom shoe to transition out of the 3D walker. So how are we doing with ankle fusions arthroscopically? Well, the next two slides show a number of series of ankle fusions arthroscopically, and you can see columns for fusion rate and average time to fusion. And for almost all of them, they show very high fusion rates and time to fusion in the under 12-week range in general. What about if we compare the arthroscopic to the open? How does arthroscopic fare in there? This 2017 paper compared open versus arthroscopic ankle arthrodesis. It was a systematic review and meta-analysis, including 1 prospective and 5 retrospective studies encompassing 286 patients. And it found that the arthroscopic fusion had higher fusion rate, shorter tourniquet time, and shorter length of stay, with no difference in infection rate, overall complication rate, and operative time. This study, comparing 29 open and 50 arthroscopic procedures, showed that there was a higher rate of complication in the open procedure versus the arthroscopic, and a lower rate of fusion in the open versus the arthroscopic procedures. Finally, a systematic review from 2018, looking at 7 retrospective studies, showed that the arthroscopic procedure had better clinical scores, fewer complication, shorter hospital stay, and less blood loss, with similar union rates, reoperation rates, and operative times when comparing arthroscopic to open procedures. What about durability? Do these hold up over time? This study from 2018 from Rick Ferkel's group looked at 101 ankles with a mean follow-up of 7 years, and they showed 75% good to excellent results. About 85% had no change in talonavicular osteoarthritis, about 70% no change in subtalar arthritis, and 96% returned to work after arthroscopic ankle arthrodesis over time. But what kind of level of activity can you expect after arthrodesis? Because certainly in an active population, it's a pretty tough sell to do an ankle arthrodesis now that we have pretty good ankle replacements. In this study, Kirchhoff looked at sports participation, functional outcome, and complications after ankle arthrodesis with midterm follow-up. And the authors concluded that the procedure gave satisfactory functional outcomes and pain reduction, that most patients remained active in sports but tended to be at a less demanding level of activities, and the complication and failure rates were consistent with previous literature. Now, what about arthrodesis versus arthroplasty? Admittedly, arthrodesis has become a much harder sell for patients now that we have a procedure that retains joint motion and decreases pain. Mefuli in 2017 performed a systematic review comparing ankle arthrodesis and ankle replacement. He concluded that although there is some evidence to support total ankle replacement to conserve ankle motion and offer improved function and decreased pain with high satisfaction rates, revision rates for TAR are significantly higher than revision rates for ankle arthrodesis. So in conclusion, I think, really you have to pick your patients carefully. You have to assess their expectations for activity level, their need for ankle motion to achieve their desired activity level, and the relative risks of failure of total ankle replacement versus arthrodesis in any specific patient. Now, if you have a practice that has a nice athletic population, they tend to be low BMI and they're willing to accept having lower impact activities in the long term, it's certainly reasonable to lean towards an ankle replacement in this day and age. But in Wisconsin, this is my reality. For him, go for an ankle fusion. It will give him good long-term results and allow him to return to high-demand activities. In conclusion, arthroscopic ankle arthrodesis has benefits over open arthrodesis. The results of the procedure hold up over time, and the procedure allows most patients to return to work and some sports activities. Thank you.
Awesome. Mark, Bernard, thanks for a great session. I know your two guys weren't present in person, but they gave great talks. So I appreciate the time. I want to thank Arthrex for sponsoring this past hour. And you guys, you're second to last. So we appreciate your time. All right. All right, guys. Thanks. We will reconvene in 2 minutes.
Thank you for having us. Thank you, everyone.
Congratulations, Selene. Keep it going.